Good afternoon, everybody. My name is Katrina Hoff. I'm the director of the Southwest Idaho Area Health Education Center, and welcome to our first session in our 25-26 CE series, conducted in collaboration with Full Circle Health. And today we have Dr. Nguyen talking with us about MAT and OUD in pregnancy. Just a couple of housekeeping items. One, you can post your questions in the chat as we go, and you could also ask some questions at the end if you like. I also will have a disclosure posted in the chat, but it is basically that no one involved in planning or presenting this activity has any relevant financial relationships to disclose. And so with that, I will hand it over to you, Dr. Nguyen.
All
Sorry.
right. Thank you so much. Hi, everybody. I hope you're doing well today. I'm presenting a topic that is near and dear to my heart. I think it's just really interesting, and it's one of those diseases that we still have a lot of work to do, especially for certain populations, such as in pregnancy. So I hope that, at least a little bit, I'll be able to share some new knowledge with you guys. So we'll just get started here with that. Oh, and this is the accreditation and disclosures. I have no financial relationships to disclose to you guys. I'm not getting paid for doing this or anything. Okay, and so really one of some of the things I hope we get out of this is like just reviewing MAT in pregnancy and then going over some of the statistics around that and in America in general, why it's important, and then reviewing some guidelines for it, and then deciding, what you should pick between like mono product for buprenorphine or combination product for buprenorphine or methadone. So kind of going over some of those things here with this talk. And I figured some of the things we could talk about first is going through a timeline of, drug enforcement laws, and then sort of like how America in general has reacted to illicit drugs and trafficking, and sort of like the progression to the war on drugs and some of the more recent things that we've done so far. So as you can see, the first ever drug control law in America was passed in San Francisco, and that was in 1875. And then, of course, as we go through 1910s and 1920s, marijuana was actually one of the more crackdown illicit substances at that time, but mostly they just taxed it and sort of tried to regulate it that way. And then somewhere in the middle of the 1920s and 30s, of course, prohibition and the 18th Amendment was also in the mix there. But of course, we don't make alcohol legal anymore, so I didn't really add that on. Otherwise, as you can see here, in the 1970s, the CSA was created, and that really started to look more closely at the manufacture, use, and possession of substances. And then the Drug Enforcement Agency was created under Nixon, and then his first lady was very involved in creating the Just Say No drug campaign in the 1980s, and that was more efficiently, more colloquially named the start of the drug war, or like the war on drugs. And then more recently, in 2009 and 2013, about 40 states in the US started to kind of backtrack on such crackdown on substances, because, we were there was a lot of people viewing that, there was a lot of racism involved in that, very like African American and other marginalized populations that it seemed like America was just focusing on with these types of war on drugs. And then around 2010, they created the Fair Sentencing Act, which kind of backpedaled more on some of those minimum drug sentencing. Okay. And then we'll just keep going here. So I think this is a really important topic because we see a lot of addiction problems in our clinics in family medicine. And one of the populations we don't talk about as much is in the pregnant population. And there's still a lot of stigma around that. And later on down the road, this affects us in many other different ways. Like when we're caring for baby after delivery, there's, NOWS and NAS that we have to worry about. And then we're kind of coaching people through, are there going to be any long-term effects on baby after, you have a mother who has OUD or has had opiate exposure and they kind of want to know what to look out for. Or sometimes you just kind of lose track of those patients because they kind of just fall off the grid. So there's a lot of socioeconomic challenges for these types of families. And then there's a lot of comorbid mental health disorders as well. And of course, there's a lot of economic burden on the healthcare system because of OUD and, in my opinion, a little bit of inadequate, well, maybe not a little bit, maybe a lot of bit of inadequate response in terms of this disease. So um, epidemiology, I wanted this to be a little bit more interactive, so I added some questions that we can kind of think about, and if anybody has any answers or thoughts on it, they can kind of share. But how many people in the U.S. do you think are affected by OUD? And then, one of the more important things I want to know is compared to men, how do you think women are affected, and how many are affected compared to
Hey,
men? And then, sort of, how does that translate during pregnancy? Does anybody
So,
have like any thoughts on like any of those questions? If not, I'll just kind of roll along since we've had a couple of minutes to sort of think about it. And then I guess I can check chat too. Okay. All right. So if not, then we'll just kind of move. How do I get rid of this? Okay. And then we'll just sort of move along. Okay, so as you can see here, this is a pretty common chart that you can see if you like look up opiate overdose deaths on the CDC website. And it was right around like the mid 2010s that we started to really think about the sixth vital sign is what they called it, and they added pain in addition to the other vital signs that we're all kind of aware about. And so there was a really big push at that time for providers to really address pain as part of their like initial assessment of a patient. So lots of like prescription opiates are being kind of pushed along like the 2000s to the 2010s. And then right around 2010, we started seeing more heroin in the streets. And then you can see like a rise in heroin overdose deaths at that time as well. And then starting around 2013 to 2015, we started to see more of the synthetic opiates that are more potent and easy to traffic being mixed in and being more accessible. So at that time, you can see that there was really a big jump in like overdose deaths at that time because of that. So let's see. Oh, so it's quadrupled since 1999. And then some interesting facts I found out when I was doing some more research into this topic. So 3.7% of all US adults required OUD treatment, but only 25, so a quarter of these 3.7% of the US received any medications for OUD. And then, of course, there's a higher percentage of men in their 30s to 40s, so mid-age range, receiving the medications for opiate use disorder than any women or younger or older extremes of adults. Okay, let's see. And so this is just the same chart, but broken down into male and female. So you can see that there's still more deaths in the male side, but they rise just the same, following the same trend. And so I wanted to also bring up this chart that shows like which states are highest in dispensing opiates, so prescription opiates. So you can see that really in the southern region of the US, it's the highest. So starting from Kansas over to Kentucky and Tennessee and Alabama. And then Idaho, of course, is in that moderate range over here on the west side. And so here is the rates of providers dispensing buprenorphine. And as you can see, some market difference. So again, Idaho is in um, that low category of dispensing buprenorphine. And then some other things, you can see that some of the states that's most affected, so Kentucky and Tennessee and Alabama, are still doing pretty good at keeping up with dispensing buprenorphine. But Kansas, you can see, and Oklahoma and some of the other states in that mid-southern region aren't doing as well. And what I found is there were some studies into this, and they really found that Kansas in particular lacks like a high quality opiate addiction treatment program. So there's still lots of gaps, just like even looking at like the gross data of providing adequate treatment and available, accessible treatment for opiate use disorders. And so some other considerations for the actual pregnant patient and the baby is that women in this population have a lot of socioeconomic burden. So in addition to having poor nutrition and access to like safe resources, accessible resources, they also have higher risk of hepatitis and HIV because of the uh, association with injectable illicit drugs. And then they also have a lot of comorbid mental health disorders, and are increased risk for postpartum depression. And particularly among women, there's still a lot more stigma compared to men suffering the same condition, just because I it's really hard to be a woman in this country and to be expected, there's this burden of being like, oh, you should be a great parent, and you should provide for your child. And um, there's still a lot of stigma around that, and you can't be using drugs on the street because you have a kid now. And so there's a lot of stigma on the mom, and that might prevent them from wanting to get treatment for this because obviously they want to hide something like this. And for as far as effects on the baby, there's still ongoing research on like long-term things, but as far as intermediate to short-term risks, of course, we already talked a little bit about neonatal abstinence syndrome. So like any substance that mom takes during the prenatal period, if it gets passed along to baby and baby gets used to that substance, after delivery, they start to have a lot of different symptoms. Usually, when it's associated with opiates, they go through the opiate withdrawal. So, like really fussy, irritable, diarrhea, poor feeding. They have that signature high pitched cry, all those things. And then there's been some studies that do show that long term there's a potential risk for behavioral, emotional regulation for children exposed to opiates, language development, cognitive motor development. And then, of course, in the short term, there's a higher risk for premature birth and then lower birth weight. Okay, and then we can kind of see this trend showing the neonatal abstinence syndrome births in the US kind of follows the same trend as that graph I showed you a couple of slides ago, showing the rise of opiate use disorder deaths, related deaths. And so in consideration for the pregnant population, I already mentioned there's monoproduct, so just buprenorphine, and then there's a combination with naloxone, and then there's also the option of methadone. And so traditionally in the past, some people have wanted to just do buprenorphine monoproduct because there was some concern about side effects in pregnant patients or on the fetus because of naloxone. But one of the things I will mention is buprenorphine monoproduct has a higher risk of diversion and misuse just because the monoproduct could be turned into an injectable product. As far as availability, of course, if mom were to just swallow it, it's not as bioavailable PO. And same thing for breast milk. So we typically encourage these women to still breastfeed unless they have other contraindications to breastfeeding. Otherwise, I also included a little chart that kind of shows like the receptor subtypes that are involved with methadone. So methadone has mu1 receptors, mu2 receptors, and delta and kappa receptors. And it kind of shows some of the effects with having those receptors activated. Of course, mu1 is related to that euphoric type of feeling with the opiates. But then you can see some of the other effects that they can be related to, like respiratory depression and dysphoria with the kappa for methadone. And some other thoughts I had for the pregnant population is if a woman is stable on her methadone dosing prior to pregnancy, before she finds out that she's having a child, usually during our management of this type of patient, the methadone clinics will kind of titrate or need to titrate because their metabolism is just different during pregnancy. And so you might see a little bit of that. So they might have fluctuating dosages of methadone. So it'll be really important to kind of track down what they're taking every day. And then another thing is minimizing the amount of methadone that people get during pregnancy doesn't decrease like NAS for the baby after delivery. So really you should aim to adequately and fully treat mom's symptoms and getting control of her symptoms rather than trying to minimize risk that way. Okay. And then we'll move on. So, some more comparisons between methadone and buprenorphine is methadone has a lot of drug reactions that are possible. So I included just a list of some antibiotics that can interfere with the methadone. And then, of course, it prolongs your QTC interval. So you kind of have to manage get regular ECGs. Usually it's annually, but if there are any concerns, you can obviously do more ECGs during the prenatal period. Because methadone is so highly regulated, you need to go to the methadone clinics to get that. We're not able to prescribe it for opiate use disorder. There's a lower risk for diversion. For buprenorphine, though, the benefits is you can start it in the outpatient and you can even do home inductions if the clinic is prepared for doing that and coaching people through that. There's fewer drug reactions, and there's one of the things that is something that I should mention though is a rare risk of liver dysfunction that can happen with buprenorphine compared to methadone. But otherwise, overall, I think it's more accessible. And then it does show that people who are on buprenorphine have less severe NAS, and then their hospital stay for the baby is shorter when compared to methadone. Um, in other cases, the only other thing you kind of have to keep ahead of is there's a reported risk of diversion with buprenorphine. So that's the other thing to kind of consider. Okay. And then some more recent updates is around 2023, there used to be a restriction on prescribers to prescribe buprenorphine for OUD, but now any provider that's licensed to prescribe Schedule 3 controlled substances can initiate treatment with buprenorphine. So I feel like this is something that people should feel empowered to be able to provide to their patients. Okay, so moving along, we talked a little bit about office-based and home-based initiation for buprenorphine. And so I'm gonna just show a little bit, a couple of slides of common induction and maintenance schedules. And this can vary from clinic to clinic. It can vary from provider to provider. But the gist of it is about the same. You kind of, for buprenorphine, you want the patient to subjectively rate themselves in the moderate range of withdrawal. So usually that's like a cow score of or sow score of about 12, anywhere from 12 to 17. Again, it depends on the clinic in terms of what like actual number to use. But then they kind of start with about 2 to 4 milligrams, and then they instruct a patient to take another additional 4 milligrams depending on their symptoms. Okay, so here's a another slide showing like a different induction, like a home induction schedule. So it kind of walks you through if like day one, you feel fine, then you take 4 milligrams in the morning, and then if you start to feel withdrawal symptoms, then you bump it up to 8 milligrams, and then sort of going through that. Okay. Of course, we still need further research for buprenorphine, long-term effects on mom and baby, and then they're still doing some more research on combining buprenorphine programs with psychosocial treatments at the same time, which is really great. So I highly support a multidisciplinary approach when it comes to opioid use disorder, and I feel like that's going to be really important to really fully address and get the patient plugged in so that they don't just fall off the grid. Okay, so and then now we're going to go into like some of the best evidence and some recommendations I have. I do think that if there's any concern for opiate use disorder, or if the patient shares that with you, they're as part of their prenatal care, they should be recommended to start on methadone or buprenorphine. And then they should also think about, you know, whether or not they want to do home induction or just outpatient supervised withdrawal. If they're farther along, that's the recommendation. And then, of course, while we're in the hospital, we talk about nows and monitoring baby in the hospital after delivery because of that. Breastfeeding, highly encouraged. And then also getting them hooked up with mental health support, also highly encouraged. And then thinking about long-term family planning for these patients even after this current pregnancy. Some of the screening tools we can use is the 4Ps, which the NIDA and the CRAFT, which I can show you guys in the next couple of slides. And then what they found is typically people who have opiate use disorder might also have other addictions. So, if they are presenting with that, obviously we should encourage cessation or support them through reducing that if possible. Um, Let's see. And then other things to think about is that hooking people up with therapy for these diseases also help improve adherence to overall prenatal care. So I really encourage people to think about that. So here's an example of the NIDA. So on your left side is the NIDA screen, and it kind of walks you through a paragraph of what to say if you can't think of how to best get into it. And then the 4Ps, and then if any of these are positive, doing some more digging into that. Okay. And then some other food for thought. So these are like the kind of random thoughts that I had while researching this topic, and I didn't have a good place of putting it anywhere in my presentation. So I kind of added it at the end here. But one of the other trends I noticed is the states with the highest rates of prescribing opiates also have the highest rates of NAS. And then, it's also affected by global warming, surprisingly, because it's expected that in the future, with global warming and severe weather ranges, there will be a disruption in the illicit drug supply chain, and people are going to increase the potency of opiates and then potentially get around the supply chain disruption with that, and there's going to be an increased risk of overdose. And of course, the economic related effects of opiate use disorder and NAS on our healthcare system is high. And right now we're understaffed and undersupplied for current demand. So I can't imagine in the future how that's going to change, probably worsening. And then that's just my references. So um, that was my talk. If there's any questions or anything, please type those in the chat or turn on your mic if you'd like, and I'll try my best to answer. But um, if there are any questions, just let me know.
Hey, Amy, can you hear me?
Yeah,
Hey, great talk. I have a question for you related. If you have a pregnant patient who is on chronic opioids for pain,
yeah.
what do you kind of do the same thing that you just talked about in this talk with them, or how do you approach that? Is it different?
Yes, so we definitely approach them just the same. We except that we now know they have chronic opiate use, right? And then I would suggest to them whether or not they would be amendable to starting either methadone or buprenorphine. Probably would push buprenorphine more, but either way, would want to talk them through like, are they interested in potentially getting treatment? Or are they interested in stopping? Because sometimes patients are just, as soon as they know they're pregnant, they want to stop cold turkey, but that's kind of rare and has higher risk of relapse, of course. But usually the gold standard is to try to get them into one of these programs if they have a known history of chronic opiate use. And if they have like, medications they're taking for pain already, then we try to kind of wean them off of that as best we can, and move them over to either buprenorphine or methadone. And if they're unable to tolerate either of those, then I would probably recommend getting like a pain specialist involved.
Great. Thank you, Amy.